Thank you very much, Dr. Kibler. Can I ask all the speakers to come back to the stage, please?
Okay. We have some time for questions, please. Any question from the audience? First talk was Philippe Hardy talk about osteoarthritis. Philippe, any place for debridement and bicep tenotomy in young patients? What the results before the prosthesis, glenoid prosthesis component that you advise us? Any place for debridement and tenotomy?
No, I'm sorry.
No?
No, you can do tenotomy, it's a good operation, but not for these patients.
Not for this patient.
I've tried many things. I've tried to do everything you want: shoulder arthroscopy, lavage, debridement. Some propose to make just debridement of the rotator interval and biceps tenodesis. Nothing is as good as a total shoulder replacement.
Okay.
Any other questions? So does anyone has questions for Dr. Zhang? I have one, if I may. So you said that in suprachromial impingement, it's important to go to conservative treatment first before considering surgery. So my main question as a physio is, how long do you think that we should try conservative treatment before saying that we failed?
You mean the outlet or suprachromial?
Outlet.
Outlet, okay. For me, it should be for the rest, change of daily activity and with some NSAIDs for about 6 to 8 weeks. If it doesn't, improve the symptom, I'll give him or her an injection for another 8 weeks. So that's about 3 months. Yes. For some patients, I do about 10 weeks. That will be 4 months. So 3 to 4 months for conservative. If the patient does not respond to this, then I'll discuss with the patient and maybe I put some surgical intervention.
Dr. Yang, in some cases, it's very difficult for us to know if we are facing a grade 5 or grade 4 subscapularis tear or anterior humeral head subluxation. And in the case of grade 5, if you resect the coracoid, you are getting in big trouble because the head is going to be all the way up. Is there any trick to really know if you are facing a narrow coracoid humeral space or a grade 5 Lafosse subster?
I got to be honest, I've only done about 2 cases of case 5. So case 5 is, type 5. Type 5 is very rare. And usually it's a fresh injury. It's not a very chronic one. And if you got a chronic one, it's usually an anterior subluxation. So that decrease of the subcoracoid distance is not because of the impingement. It is because of the loss of the subscapularis. In that case, I will never do a coracoidoplasty. So once again, coracoidoplasty is a very vague and confusing, definition. I don't promote that. The case I show, I do very little. I've done about nearly 120 cases of subscapular repair. Only about 10 coracoidoplasties. It's less than 1%, something like that. So I'll be very careful because I cannot give you a very straight and clear outline how is impingement and how to do a coracoidoplasty. I can't tell you that.
I just throw this out for you all, remembering that so far the way we look at impingement is that the rotator cuff goes to the acromion or to the scapula. I would suggest you also think about the times that the acromion or the coracoid goes to the rotator cuff. Because in both situations you can see this particular problem of a protracted, internally rotated situation right here, and you will, that's a dynamic space. Both those are dynamic spaces. And I agree entirely that right now we have no definition of coracoid because that thing moves every which way. Now there is anatomy, that's true, and some of them will be angled, but it's a dynamic issue. And that's why also why the bone spur on the subacromial space has no relationship to the treatment, because that's a dynamic thing too. So rather than, once again, make all your diagnoses of impingement on that, that's why the exam and then those corrective maneuvers that I showed you can really help you in understanding when you have to do something. For example, the coracoid, if I get them back this way and I get the rotation here and they don't hurt, then the coracoid anatomy is not the problem. It's the subscapularis anatomy that's the problem.
Question? Philippe?
I have a question about the internal impingement that we call in France posterior superior impingement, following Gilles Valche, which is maybe it's a question for all the speakers, because usually when we want to treat something in medicine, we try to treat the cause, and probably the best way to treat this posterior superior impingement or internal impingement is to tell to the patient, stop the throw.
Yeah.
So stop to throw,
Right.
difficult to say to the thrower. So the second option is to say, okay, we say that, we read that in all the paper, change your way of throwing. Okay, easier to say than to do, of course, but probably it's the way. To face this problem, now we try sometime to treat the cause, I mean the impingement itself. Maybe it's not the best way, but I would like to just mention the proposal of Christophe Leving, you know, who is doing arthroscopic posterior superior resection of the glenoid rim. I did some cases like with quite surprising good result, and he showed a small series with good result. What do you think about that? If you are facing a throwing athlete, professional one, the physiotherapy cannot solve the problem, so then you have to do something. Do you think that this kind of surgery can be interesting for him?
I have no experience of that. So you detach the labrum, you burr the glenoid, and reattach it?
You do an acromioplasty of the posterior superior.
And you reattach the labrum later?
Usually you let
I haven't done it, but you get the same results you get with the chromioplasty for impingement, which is not good necessarily, especially in a younger person. You know, I don't know what age group or what they're talking about or how often they have to do that. And what you're doing is you're getting rid of some of that pain and that impingement. You know, that's what you're doing. You're probably setting up a situation where you can do the exercises properly and do all the things that we do. Otherwise, if you take all that labrum off, then you've lost the washer, you've lost the tension band, and so I'm sure there must be. Remember that attaches more posterior, so you can take a little bit of that bony rim or that articular margin there and get away with it, probably. But if you take that lesion, if you take it off where it on that posterior ridge right there, then you've destabilized the joint fairly significantly.
You can leave almost all the superior labrum, in fact.
Well, yeah, so what you do, you're not doing a chromioplasty, you're doing a chondroplasty. You're removing all that junk back there.
Okay, thank you. I have a question for Dr. Itoy.
Okay.
You said that by nature the pus. Oh, you wanted to comment?
Yes,
yes, you do.
Yes, because
no
he
problem.
asked all the presenters about his question, and I think the internal impingement is the result. And what is the cause? I think it's the form of throwing. And the throwing form is not so good, then you may have a very strong internal impingement. What causes bad form? I think it's the stiffness of the joint, like hip internal rotation is very stiff. Then you cannot rotate the pelvis sufficiently, or you cannot rotate the trunk. Then the thrower must hyperextend the arm in this position. That causes internal impingement. So without correcting this, you just fix the cuff lesion. The same thing happens sooner or later. So I think it's very, very important to do the physiotherapy and also the correction of the form.
You have to identify the fact this is tight on your physical exam.
And if it works, that's fine. But if it doesn't work after correction of the form, then you have to think about debridement or regeneration if possible. That's my comment.
In my experience, we don't have many pitchers in France. Throwers we have are stone throwers in demonstration. This is the main number of throwers we have. But we have tennis players. For the high-level tennis players, really high level, international level, I don't think there's any place for surgery. Really high level. I I don't know any of them who had surgeries with cuff repair, whatever you want, except something, fixation, tendonitis, and went back to the same level. Either you correct them with Ben's protocol that I use a lot, and they can still play with you correct the movement, and you correct all the chain, and they're doing fine. But if you do surgery, it is the end of their high-level career.
But you know that all of them, they end with the surgeon, because they try to find a solution, and if it doesn't work at the end, you see this patient in your clinic, and this is where it's very difficult to make a decision.
But so then they say, I had surgery, I have to stop tennis. But in fact, they've decided before they have to stop tennis.
My practice is a referral practice for overhead athletes. So I am at the end of the line of this thing you're talking about. But they still have, the large majority of these still have these problems, just like I showed this right here. And you demonstrate to them that they can't stand on one leg. You demonstrate that this rotation is bad. You demonstrate that if I take my arm this way and it hurts and I stabilize your scapula and it doesn't hurt, there's a lot of things they can work on even at that level. The statistics are now that with a demonstrated anatomic labral repair, 50% will not need surgery with a proper rehabilitation program. So it's almost like a victims and culprits. Okay, this is a victim, okay, so let's treat it. No, we got to treat the culprits. All these other things going on.
Dr. Gibler, can I ask you one question? The big problem that we have in Europe, you understand, basically is when we are talking about throwing shoulder, is about a pitcher in baseball. You understand? In Europe, we have also 300 million people. We have about 500 pitchers, but we have 15 million handball players, and that is for us throwing shoulder. And I listen to you because that's that's sport-specific way of throwing in pitchers. In handball, they are doing about 60,000 or 100,000 throwing per year, where the ball goes 120 kilometers. That's extreme demands. And most of these players, if you see, they play or they train with ankle sprain, because that's the most frequent injury. And there is no, and some of them, they don't have any problem with the shoulder. Some of them, they had ACL surgery and so on, who is now frequent, and they don't have a problem with the. For me, it's difficult to understand how can I transmit or to put all this that you have constated from the pitching, where they have the time to throw and so on, without changing their technique, because in handball they can change the technique of throwing.
Yes,
and you can help us a little bit.
Yeah, and that's why the sports specific thing needs to be. For example, tennis players. I work with all the professional tennis players as well, and that's slightly different, but they still have the same loads. But there's a little bit different profile of how they use their arm, but they still have the same issues down here. Now, one of the reasons I want to come over here, and Philippe was telling me about, is that I like handball. I see it from a distance, and to understand that would be, you need to do the same types of studies of the mechanics and the throwing and the loss of motion, scapular control, all these kind of things, to see if they exist. They may not exist. If they don't, then no problem. But you need to get this musculoskeletal profile of those athletes, which sounds like you all have a chance to do here with this control.
Yeah. We have the same, the circumstances in China, because baseball in China is not very popular, not like in Japan and in Korea. Although they're all throwing shoulders, I think in China, the handball and volleyballs, they're mainly throwing shoulder, but they're very different from pitchers. They're two different games, and their personality is very different. As to answer your question, I think why they can still have a very high speed with an ankle sprain, because the handballs and the volleyballs, when they do the spike, when they do the throw, they jump off. Okay? Well, they have their shoulder in the air without any trunk, because they jump first, then they get it. That is very different from a baseball.
Handball players get to run. Baseball pitchers have to stop right here. So there's a difference, but now you lose a little bit of your ground that way, but you get your momentum for there's your internal system of actually having some forward momentum from throwing that you don't have in baseball, for example, or in tennis.
And the speed is important because they throw the ball at 130 maximum. And when I see the tennis players, the old one, when you do biceps tenodesis, they can go up to 160 kilometers with the tennis ball, but they have no chance they can go to 200. Without the biceps, you cannot go to 200 kilometers.
What's kilometers for 100 miles an hour baseball?
160. They cannot. Without the bicep, they cannot do it.
Any athlete can do about 80% of max without having any pain. It's that last 20% of max, which makes them a professional, which makes them good, which they can't get if they don't have the good kinematics.
And handball, they can have contact. Normally, tennis players don't.
Last question. Mike, over there.
Hi, thank you for this day. When you have a partial thickness supraspinatus tear, say it's a pasta injury, do we need to inject, or are there any cases you don't inject, or are we contributing by making things worse when we inject?
You mean the local anesthetics injection into
steroid
into the glenohumeral joint?
Yeah, just because you said they all get worse. So if I'm injecting, am I making things worse for athletes?
Well, it could, because if you remove the pain, then they may do the bad, throwing more and more. But for the, if the patient has a game tomorrow, then the injection really works. But after that, it may be aggravated. So if you repeat that again and again, that will make the tear even worse. So, but sometimes, players come to see us and said, "Doctor, please give me one shot because I have a very, very important game tomorrow," something like that.
Are there any sort of tears that you don't inject? You say no for injection?
Well, I think it depends on the situation, and I have to make a decision on a case-by-case basis. Basically,
yeah, I don't inject. Yes, the number of tears, 0. What are you trying to do with an injection?
I'm trying to ask you to know, to learn. So
why would you inject somebody? It's because they've got some swelling or they got some pain. Because you know that the injection is not going to heal anything. So if you got a lot of acute inflammation, acute soreness, they came in, boy, they're sore. All right, you can make a case for an injection, but see, remember, if this partial tear, where are you going to put it? Inside the joint or superior, on top? But anything else, there are other ways of getting rid of the pain besides doing, especially since that's going to be a short term. And there are a lot of deleterious effects to steroid injection that, for me, are not worth it. So the only time I ever inject anybody is when they're acutely flared, or if I need to get started on rehabilitation. But other than that, it's not diagnostic. It's really not therapeutic. You don't, the studies show that half the time you don't get it where you want to put it. So unless you do an ultrasound guidance, then there's a question of whether you got it in the right place. So there's a lot of factors go in about whether you're going to inject something and where you're going to inject it.
AG,
yes.
Last two short questions. One, is there any place for PRP in pasta lesion to inject the patient with platelet-rich plasma? Question number one. And where does the stiffness come when we fix a partial calf tear? Because some patients develop a kind of stiffness, like a frozen shoulder. You're an expert in frozen shoulder. That is, we can say that perhaps to over-tight the calf 1 or 2 millimeters are the cause. The cause of the stiffness is biomechanical or biological?
Okay, the number one question, PRP.
Yeah.
There are several studies showing the result of PRP, and I don't have any personal experience, but those using PRP, they all say this is effective for the healing of the tendon. And for the stiffness, I think it's a pure biomechanical issue.
More biomechanical than
Yes,
biological.
because you shorten the tendon. If the tear is 5 millimeters, you resect that area and you shorten the length of the supraspinatus tendon muscle unit. That causes stiffness.
Not a kind of adhesive capsulitis after the repair.
That could be a cause, but I think the main factor is the
mechanical.
structural change. Yes, biomechanical thing.
Okay, we are done. Thank you very much, all the speakers, and thank you, Philippe. See you tomorrow morning.
See you tomorrow at 10. 10 tomorrow morning.